Thank you. And Herb asked me when we were talking a bit before the conference if I would talk a bit about my background as well. So how does one get to be the engineer/surgeon working on surgical robots? So I am not one of those people that wanted to be a doctor ever since I was about 2 years old. I was really much more on the mechanical side. I liked taking things apart, and most of the time they went back together again. This is my motorcycle when I was in college. I ended up at MIT building robots. And also as a sideline, I was working with this gentleman here, Ernesto Blanco, who had done a lot of work in medical device design. And so I got a little bit of a try of that, but my real love was building and racing electric cars. And so I went to Australia as part of the first World Solar Challenge and raced from Darwin down to Adelaide. And there was all kinds of press. This is about making light of the race with the sun. Just a little bit of trivia. That bottom there belongs to the Chief Technology Officer of the United States, Megan Smith, and she knows that I show this picture. I sent it to her because she wanted it too. And Sunracer beat us soundly, and the press was not quite so generous with us after we limped across the finish line. But if you can't beat them, join them. And I went off to work with Paul MacCready, who you may know of as the father of human-powered flight, built the Gossamer Condor that flew across the English Channel, and also was building pterodactyls, all kinds of really interesting things. So I went and worked with him, and I was building hybrid electric off-road vehicles, unfortunately for the military at that point, because they were the ones that had the helicopters that you could have them inside and then come driving out really fast, and that was a lot of fun. And I was also working on fuel cell systems for a high-altitude aircraft, which is the Helios up there. Then I went to medical school. And you might wonder, what on earth kind of a break is that? But in the theme of reinventing oneself and always being on the steep part of the learning curve, I had become somebody who was managing people who were managing people who were doing what I'd originally gotten into engineering for. And I was looking for a demotion. And let me tell you, going to medical school is one hell of a demotion. You are now on the bottom of a very large totem pole, but it is a place where you can explore. And you can't take the engineer out. I designed a device, a medical device, while I was in med school and started a company as well. And I also had my daughter while I was in medical school, and amazingly enough, eventually did graduate. And at that point, I decided not to practice medicine. I went into building robots again. And what a lot of people think about when they think of robots, especially from that particular era, is something that looks a bit like this. And that is not at all. We don't build robots that are autonomous and want to come back from the future and kill you. Nor are we working in the world of these small robots that are either companion robots or cleaning up your floors. It's amazing how many places robots have come into our lives. They're on the manufacturing floor. We've got robots that are helping move parts around and also doing the actual manufacturing. And we're going to see robots kind of come into our day-to-day life in the form of self-driving cars and in the form of drones and deliveries. The kind of robot that I work on is in some ways a lot more personal and a lot less personal. It's a surgical robot, and this is an extension of the surgeon, allowing the surgeon to do more precise surgery through very small incisions on the inside of the body, minimizing the cut, but maximizing the efficacy of what it is that you're doing inside. Now, when you invite a surgeon to something like this, you're going to get surgical images, and the next image is one of those. So avert your eyes if you're squeamish. But up until the mid-1980s, this is what surgery looked like. If you needed to tinker with the machine, you needed to open it up. And you needed to make an incision big enough to be able to get your hands and your eyes inside. And it was in the late 80s that laparoscopy came out, and surgery started to look a bit more like this. Surgery on the end of a long stick. And you place that stick through the abdomen, and you can then work with a camera on the inside and be able to work. Now, I usually bring a pen up, but I didn't. But imagine now taking a pen and putting it through your hand and then trying to write your name on the other side. When your hand moves left, the tip of the instrument moves right. And when your hand moves right, the tip of the instrument moves left. And so now you're doing something as complicated as surgery through this interface that essentially puts everything backwards. It's learnable. And it is done all over the world on many different types of surgery. But different types of surgery are more or less amenable to this minimally invasive approach. The more complex the reconstruction, the more you need to do sewing, the less likely it is to be done minimally invasively. And it was into this niche that the product, the Da Vinci robot, was designed to be able to bring it possible to do minimally invasive surgery at any level of complexity of surgery. And so video will have a little bit of surgery in it too. This is the business end. This is the instrument. And it has a wrist, and so it can mimic every motion that the surgeon's hand does. And so as the surgeon at the console makes a motion, that surrogate hand on the inside is making that exact same motion so that you can do very fine stitching. And this suture is about the size of an eyelash. But what that means is that you can do a repair in the heart from the inside, and all you're doing is putting an incision in between the ribs. And so somebody can go home from something like heart surgery with Band-Aids on their chest instead of the chest cut open. And so more and more, ORs are starting to look like this. There's over 3,000 of these robots in hospitals all around the world, and more than 500,000 procedures being done robotically every year. And the big idea behind all of this is we go from the open incision, where you can get your hand as the surgical instrument inside the body, into small incisions, because you're putting a small 8-millimeter instrument inside the body. And so over the years, it's been adopted in quite a few areas, and there's data to show that being able to make that incision small means that you're bringing complications, and you're bringing readmissions, and you're bringing mortality down. And in the world of data visualization, in the US, at its peak, minimally invasive prostatectomy, surgery for removal of the prostate, was at about 4%, which meant that 96% of men who needed their prostate taken out had an open surgery. With the introduction of being able to do this robotically, that has flipped over, and now almost 90% of men who need prostate cancer surgery will get it minimally invasively in the US. And in the UK, where there was already probably about 20%, that has grown on top of that, but we're not seeing numbers up in the 90% yet here in the UK. In hysterectomy, the surgical removal of the uterus, again, complications and readmissions come down. And we saw in benign hysterectomy, one of those operations that actually had been being done laparoscopically, with the introduction of this, the percentage of laparoscopic continued to go up, the percentage of robotic went up, and it was open surgery that dropped precipitously. And in malignant hysterectomy, it was similar to the prostatectomy in that it was a bit too complex to be done laparoscopically routinely, and we saw this kind of a flip happen in the market. All because of this, the big incision to the small incision. And so we've got really fancy high-tech instruments inside the body that allow us to do this. And now I'm going to be radical, and I'm going to say they're not enough. They're not anywhere near enough. So these instruments were unearthed at Pompeii. And if you clean the rust off them and put them on a surgical tray, they actually wouldn't look that out of place today. And part of the reason why the Da Vinci was able to be brought out into the world of medicine is because we could say, well, look, we're doing exactly the same operation on the inside of the body through these small incisions that we were doing through a large open incision. And so therefore you can get regulatory approval. But we shouldn't stop at asymptotically getting back to what we had when we had that open incision. because we've put a digital step in between the patient's tissue and the surgeon, and we can take advantage of that. So let me give you an example of why I think we need to take an advantage of that. This is a bit of an eye chart, but what it is a staging chart. If you are diagnosed with lung cancer, this is kind of a degree of badness. How far has it spread, and therefore, how long do you have to live? And so if you are found with lung cancer at a very early stage, small tumor isolated in one lung, you have about a 77% chance of seeing a 5-year anniversary after you've had that diagnosis. It drops to about 58% if that's a larger tumor, hasn't gone anywhere else yet. When it starts to locally invade and you start to get lymph nodes, drops to about 50-50 chance of, and once you start to get things moving across, moving out, and distant metastases, lung cancer that has moved outside the lung and into the brain or the bones, then you only have an 11% chance of seeing that 5-year anniversary. And our worldwide average is 15%, which means we are not finding it at stage 1 and stage 2. We're finding it when it shows up clinically, when somebody starts to show symptoms. And that means we're finding it in stage 3 and stage 4. And that means that it is pretty deadly. And I can't do anything about it. I can go and make a small incision in between the ribs, and I can take the cancer out. But if the cancer has already spread at that point, all I've done is made the surgery easier, but I haven't affected any change on the clinical outcome of that patient. And so a lot of the work that I do in medical research is trying to understand what's happening in fields outside of research. What is going to disrupt what I'm doing? What is going to change that fundamentally? And yes, this is a dog's nose. Dogs can be trained to smell cancer. And if you have them sniff this person with cancer's breath and sniff this person who doesn't have cancer, you can train them to be able to differentiate. Now, we don't know all of the compounds that they are sensitive to, but it is important to know that they can sense it, which means there must be something there that as you train this dog as a classifier, they can detect this. So there are groups like Owlstone, which is a UK company, that is starting to use technology that was used in bomb sniffing to be able to make the lung exhalate sniffing machine that can tell whether you have lung cancer or not. In addition, there's other startup companies that are looking for these kinds of biomarkers in urine, in blood, in saliva, in tears. We are shedding a molecular signal of what's going on in our body every single day. And there are thousands of researchers around the world that are looking to figure out how do we measure that signal and how do we figure out, does this person have cancer or not? But after that, what are you going to do? You've been told, oh, you've got cancer, it's probably about the size of a pea, and we found it from a urine sample. We didn't find it because we saw it. It now needs to be localized. We need to be able to find it in the body so that we can get rid of it, and it's awfully small. And so now we start to have to think about what are the imaging technologies going to be that are going to get us to the point. More surgical images. So this is a kidney, and we can inject a fluorescent dye into the bloodstream that helps us delineate where the blood vessels are. So we want to be able to see, do I have an aberrant blood vessel going in and out of the kidney? Is it well perfused? Have I clamped off the right blood vessel so that I can take a part of the kidney? These are the sorts of things that this is used for now. In the future, there are all sorts of agents that are much, much more specific than just injecting them into the blood and that will bind preferentially onto cancer cells. So instead of looking in an abdomen and trying to figure out where in this sort of pinky mess there is cancer and where it is not cancer, you light it up and then it's starry night, and if it's bright, you take it out. And that allows us to start localizing in on these smaller tumors as we're trying to get rid of them. And so then some people say, all right, so we're going to detect cancer when it's really small, and we're going to be able to localize it and probably ablate it with a needle. We'll just burn that out. What are you going to need big surgical robots for? Because surgical robots right now are, we take something big out and we do a big reconstruction. You saw we were aimed at the area where it was that gap between very complex surgeries. And we're bringing this surgery down to be a pretty simple surgery. We're just going to put a needle in and ablate it. But as we turn cancer into an ablation treatable disease with imaging and navigation, we still sag and wear out and tear. And so I'm thinking we're going into the spare parts business. Because as the people in regenerative medicine start to be able to make new blood vessels, be able to make nerve scaffolds, cartilage, the holy grail of being able to make a kidney that you can print the scaffold for and seed your own renal cells into and have them organized into a functional kidney. When we have all of those things, and we have blood vessels and bladders and tracheas now, but when we have even these higher level organs, you're going to want to put them in very, very precisely. That's what we'll do. The other really interesting thing, when I talk about asymptotically getting back to what we had when we had the open incision, we have an opportunity embedded in the middle of this necessity where we digitized every step between the manipulations that the surgeon was doing and the manipulations that are actually happening to the tissue. So we understand the manipulations and the visual stream of surgery in a way that's never been understood before. We can observe people learning. We can observe the difference between what is a good outcome case and a bad outcome case. And we can start doing big data, but really big data, like terabytes of data that come out of an individual surgery, and start to be able to feed them in and look for patterns, but also to be able to offer advice. And maybe there are ways in which we can observe the differences between novices and experts and help support those novices so that they can become experts. The process of going to medical school was sobering. As an engineer, you learn things and from first principles build up all of the work that you're going to do from there. In medicine, they dump enormous quantities of disconnected facts into you, and you have to learn them all and try to figure out the relationships in between them yourself. Computers are really, really good at that. And as we walk around with our ectopic brains and put more and more of the information that we carry out onto these, we can start putting things like Doc Watson, the ectopic brain for the surgeon, where in the middle of the operation, they can check on anything that they want to be able to check on. We really don't want it going, are you sure you want to cut that? Because that would be the most annoying backseat surgeon that you could imagine. The other interesting thing about robotics, as I mentioned, we had to cut a hole big enough to get our hands in, because these are our surgical instruments. We've always made our therapies based on the scale of what the human can manipulate. But that's not necessarily the scale that we are on. The blood vessels in the back of our eye are 30 microns in diameter, and the human hand can do about 100 microns of accuracy, which means you cannot cannulate one of these vessels terribly reliably. But if you get a shower of clots up in, or emboli up into those blood vessels, you will lose the sight to the portion of the retina that that vessel feeds. But with robotics, a comfortable motion of a hand can become microscopic or even nanoscopic. And so you can cannulate those 30 micron vessels. You could also, like in this picture, drill a hole in a single cell with a laser. So if you can look at this in very high resolution and be able to say, well, that cell glows because I tagged it with my fluorescence molecule, so therefore it's bad and I'm going to zap it. And that cell does not glow, I'm going to leave it. Now you start to be able to think about unwinding these small cancers from around a neurovascular bundle, not hacking something out with a large margin, but just taking out the parts that you really need to take out and leaving everything else behind. We also start to think about the scale of being able to bring in very small stimulators and to be able to implant them in different places. This is a really exciting one. Generally, stimulators require a long lead to come from them, and then a battery pack gets embedded under the skin. And there's a lot of work being done in midfield inductive power transfer, which sounds very esoteric until you think about it means you can put a little stimulator anywhere in the body and just be able to power it externally. And now you can go in deep, and you're going to want robots to put them in. And it is the sort of thing where we really start to do lots of different kinds of modificational surgery on the body. So I don't think of the robot as a surgical device in and of itself, more as an integration platform into which we bring all of these other new technologies that are going to allow us to affect the scale, are going to allow us to make things more effective in terms of getting all of the cancer out, are going to allow us to have sort of our backseat driver and be able to figure all this out. And so I think of it really as the augmentation of the surgeon. We're going to be able to give the surgeon surgical superpowers. And this is the way I look at the world. And I actually do have the hat, though I didn't bring it. Because I am looking at lots of technologies that are adjacent to my field. Because the disruption of my field is not going to come from inside my field. It's not going to come from new surgical technique. It's going to come from something that upends us from the imaging or the diagnostics or some new kind of power transfer mechanism. And so I'm looking at all of these things in my adjacent fields, and I'm projecting what future that means I'm building robots to meet. And so that's a really exciting place to be, but you've got to be able to keep a lot of these futures in your head all at once. So thank you very much. Sure.
First off, thank you.
Sure.
Fascinating to get, if you will, a non-digital talk at the conference, if you will. And
well, but we digitize surgery.
oh, no, absolutely. Yeah, no, definitely. So in 10 years, does medicine look roughly what it is like today, but just simply, if you will, slightly more powerful and better tools and things like that? Is there a point that you think things are actually not going to be if we were to go into a space or into a time machine,
yeah,
how far forward would we land and we think, I don't actually know what the hell to do? Would you say, let's start in America because you'll know that market perhaps better. Yeah.
So I think we should think of the era that we are in right now as kind of the era of big medicine.
Okay.
We have big interventions. We can do imaging. We can do big surgeries. I think we will move into an era of small medicine. Mm-hmm. And that's going to be characterized by early detection mm-hmm. and very low trauma interventions. Okay. So we will come to think of it more as maintenance. Okay. I mean, we don't think about infectious disease as an enormous burden on ourselves right now because we've got vaccines mm-hmm. and because we have antibiotics. Okay. It's the same sort of thing. If you have a mole on sun-exposed skin, you go into the dermatologist, they kind of snick it off, you've got the Band-Aid on your back, you don't really worry about it that much. You don't define your life before and after I had that mole taken off. Yeah. And so if we move to the point where we're treating all of our cancer that way, it's no more traumatic than that. Okay. I think we would, it's more of an emphasis on wellness and maintenance at that point.
Interesting. Now, you weren't with us yesterday. We had a couple of talks, one from Luciano Floridi, who's at the Oxford University mm-hmm. Internet Institute, and another one from Tony Hay, who was the former Senior Vice President at Microsoft Research and very much involved in the e-science agenda at Microsoft and elsewhere. And we brought up the singularity a couple of times. Yes. Mm-hmm. And as I know that you're a teacher as part of the Singularity.
I'm faculty at Singularity University, so we think about the singularity a lot.
Indeed, yeah. So I assume, given that you're on faculty, that you believe it's something that's going to happen, or is that
Well,
not?
I mean, how merged are we with our machines already? I've offloaded a lot onto this. It's not that long before this gets implanted and I start accessing it that way. In terms of, people always ask us about AI and when will the surgery be done autonomously. And I've spent a lot of time in AI. That was in my graduate work. And Danny Hillis said that the hard problems were easy and the easy problems were hard.
Okay.
It's harder to teach a robot to do sort of the activities of daily life than it is to teach a robot to beat a chess champion. Because we don't have algorithms for the activities of daily life. And so I think there will always, so this is the roundabout way to say, I think there will always be a division of labor. We will increasingly use artificial intelligence and machines and machine augmentation to offload us from the things that we don't do as well.
Okay.
But getting that human out of the loop in terms of judgment is actually a lot harder than movies would let you think.
Okay. So it sounds like you're a bit more of a technology optimist than others.
Oh, I am a techno-optimist. I think we will put this technology to good use. I am not I'm not fearing our AI overlords.
Okay. Fantastic. Catherine, thank you so much.
Thank you.
Cheers. Thank you.